Hello, and welcome to this McKnight Senior Living webinar, Patients Over Paperwork, Improving Operational and Clinical Efficiencies to Advance Resident Care During a Pandemic. I'm McKnight Senior Living Editor Lois Bowers, and I'll be your moderator. I don't need to tell you that 2020 has brought unprecedented challenges for senior living and other long-term care settings. And now that the flu season is ramping up in the midst of the pandemic, today, you're going to find today's message especially helpful. You'll hear what you can do to manage the potential twindemic of flu and COVID and what you can anticipate for next year. We'll hear from our speakers in a moment, but first we have some housekeeping matters to take care of. First, today's slides will not be available for download. Next, if you are having any audio problems with this broadcast, please first check the volume control on your device. This is the most common cause of hearing issues. The sound should be coming from your computer speakers. This webinar will include captioning throughout the presentation. The captioning box appears under the abstract on the left-hand side of your screen. To enlarge the captioning box, simply drag the corners of the box. Also, we will have time for questions and answers near the end of today's presentation. If you have any questions about the information presented, please feel free to send them directly to us at any time during this hour by clicking on the Questions and Answers tab on the left. Questions that we don't get to in real time will be answered afterwards. This educational offering has been reviewed by the National Continuing Education Review Service of the National Association of Long-Term Care Administrator Boards. It has been approved for 1 clock hour, and attendees must stay tuned to this event in its entirety during the original broadcast to receive a certificate. You can track CE requirements through the course completion tracker, which you can access through the last icon in the area below the open webinar panel. Once you have achieved 50 viewing minutes, a View Certificate button will display, and the required viewing duration will have a green checkbox. You then can view and save your certificate. A copy also will be emailed to you afterwards. Today's presentation is made possible by support from Omnicare, a CVS health company. After this webinar, you can visit the company website at omnicare.com. Finally, this session will be archived and available on demand shortly after this live broadcast. If you'd like to watch it again or tell your colleagues about it, the URL to the registration page to enter this studio is mcknightseniorliving.com/111720webinar. And now I'd like to introduce and welcome today's speakers. Jim Love was appointed president of Omnicare in April. In this role, he is responsible for all aspects of the business, including strategy, sales, account management, operations, compliance, and quality. Jim previously was general manager of CVS Health's 340B business. He was president and CEO of WellPartner, and prior to joining WellPartner, gained healthcare experience in both operations and investment banking. Nancy Losben is a certified consultant pharmacist and chief quality officer for Omnicare. She also holds certificates in gerontology and pharmacy regulations. Nancy is the former chair of the American Society of Consultant Pharmacists Foundation. Among her awards are the ASCP President's Award, the ASCP's Richard S. Berman Service Award, and the Eli Lilly ASCP Excellence in Education Award. She also received a volunteer award from AMDA, the Society for Post-Acute and Long-Term Care Medicine. Derek Darling is Vice President of Strategy, Marketing, and Internal Operations for Long-Term Care at Omnicare. He joined CVS Health in 2009 and held a variety of roles before joining Omnicare in 2018. Before CVS, Derek worked as a management consultant with Opera Solutions in New York. You can read more about our speakers in the biographical information we have provided. I've seen their presentation, and they have lots of useful information for you. So without further ado, I'm going to turn things over to Jim Love. Jim?
Thank you, and good afternoon, everybody. Well, I just start with a little commentary on 2020, which has been quite a year, right? We started off with a pandemic, moved on to some social unrest, national elections, and now the second wave the most serious pandemic to hit our country in more than 100 years. And I'd like to start by expressing my condolences and thoughts and my prayers to all of you who have experienced difficulty, families have experienced difficulty, and or lost loved ones. Our thoughts and prayers are with you. As mentioned, I had the pleasure and the privilege and the honor of getting to run Omnicare, and I started just as the first wave of the pandemic was ramping up. First order of business for me was to ensure that we could continue to service all of our clients. We did that, one, by making sure that our employees were safe and that our pharmacies remained open. I'm proud to let you all know that all 150 of our pharmacies have not lost one day of operations during the pandemic. Next, we had to work with our clients and help keep them safe. And we did things like contactless deliveries, increased med availability in a variety of different ways, and I guess like everybody on this phone became experts in virtual meetings via WebEx or Zoom or just plain old conference calls. Once that and business continuation was ensured, we turned to improving our service. I'm also proud to report that our on time and the completeness of our orders during the pandemic are consistently at the 97% plus rate, which I happen to believe is the best in the industry. We also put more resources behind our account service business, and hopefully those of you that are clients out there are feeling that as we are trying to be much more proactive with you and working with you, solving problems, etc. Once that was shored up and we we felt that we had our service levels up at the appropriate level, we turned to what else could we do. As an enterprise, CVS decided that it was going to be part of the solution to the pandemic, first with testing. Okay? As an enterprise, we've tested more than 6 million people in the country, and it's growing. We test right now about 70,000 people a day. At the Omnicare level, we partnered with states, including Pennsylvania, North Carolina, and Texas, to work with them to test patients and staff, long-term care patients and staff. Okay? And we continue to talk with a couple of handfuls of other states about providing that same service. We're ready to do that. And now as a vaccine is ready, I think you're all aware that CVS and Omnicare are one of the two primary providers of vaccines to the long-term care industry. We are working very diligently behind the scenes to ensure a smooth rollout and tracking of that vaccine, to this very, very important and very, very vulnerable community. So you will continue to hear from us. We will continue to update you as soon as we know something. And we look forward to playing a very important role in vaccinations. Coincidentally, that was made easier for us by our long history providing flu vaccines. This year, CVS and Omnicare are both on track to dispense more than twice the number of flu vaccines as we did last year. And, our satisfaction rate among long-term care clients is in the high 90% range there. So we think we have the model on how to effectively vaccinate all of your patients and all of your staff. I'll close with a little bit of a commercial. As I said, we are in unprecedented times. There is a lot of financial pressure, operating pressure, personal pressure on us and our businesses. And I think now is the time when you want a pharmacy partner that can weather the financial storm, can be innovative and work with you, can provide high levels of service through all of this. And I think we have demonstrated that thus far. We will continue to demonstrate it and actually improve upon it as we go forward. I'll leave the commercial at that. At this point, let me introduce Nancy Losben, my colleague and the Chief Quality Officer at Omnicare. For those of you out there that know Nancy, you know that she deeply, deeply cares about this industry and is one of the most talented clinical pharmacists in the industry. For those of you that don't know her, I highly encourage you, get to know her. Get to know all of her and my colleagues at Omnicare. We care deeply, deeply about this industry, and we want to be partners with you. And with that, Nancy, take it away.
Thank you, Jim. And those were the exact words that we all needed to hear, your encouragement, especially as we see the COVID numbers rise. Thank you so much for your prayers and your kindness through this all. I'm pleased to present today's agenda. I want to talk about how we can devise improved communication with ancillary providers in your facilities, a best practice for decreasing some administrative time that's spent with the management of medication and pharmacy services. Let's face it, in long-term care, we certainly do not perform surgery, but we do spend an awful lot of time administering medications to chronic care patients, and we need to streamline that. We're also going to take a look at how to select some of the best tools to assess residents during COVID-19 and the flu season to assure that you have made the correct assessment to inform physicians and also comply with regulations provided for skilled nursing facilities and best practices for assisted living facilities. And finally, discuss the importance of vaccinating all of our residents and our staff, not only against flu, but pneumonia as well. What I'd like to do, however, because of the pandemic, is let's start out with flu, because I know that you're in the throes of that at this very moment. Here is where we can begin to assure that 2021 is a much better year than this year. When you take a look at why vaccine for influenza is important, let's say and agree upon that it is more urgent than it ever has been. With the explosion of COVID infections, our hospitals are at capacity, and we can help that by assuring that our residents and our staff do not need the services of a hospital because of influenza. We'd like to also minimize the sick days of your facilities staff and, of course, make sure that they are well enough to meet the needs of their family. Unfortunately, in 2018-2019 flu season, only 67% of nursing home staff received a flu vaccine. And while that has improved into the 80s last year, it certainly does not meet the Healthy People 2020 goal of 90%. And it appears that hospitals are well exceeding 92% of all of their staff being immunized for influenza. We need to do this to ensure that we shorten the duration of the disease and lessen the symptoms for our seniors, and also keeping in mind that these low vaccination rates amongst our workers may put our residents at increased risk for influenza-related morbidity and mortality. After all, just like COVID, the flu will be introduced to the facility. The residents certainly are not the ones that are bringing it in. And we need to convince our staff now more than ever, if they have any fears, that vaccinations are just the right thing to do. And we're also seeing across the country, many states begin to initiate mandatory vaccinations for healthcare workers. There's also so many benefits of any kind of vaccination for our residents and for our staff. I think we can all agree that vaccines are the best value in all of healthcare because of their cost savings to medical practitioners and the use of medication, improving health and outcomes, and especially in the area of productivity. When we see so many sick days used because of influenza every year and now COVID, what we can do is assure that we maximize the staff available by immunizing them. We also take a look at care-related productivity gains. When we take care of the caregivers, we release them to do hands-on care and supervision for seniors because they are now healthier. There's also community gains, lower risk of antibiotic and antiviral resistance because of the decrease of influenza or its symptoms or duration of effect. We all know by now that there are tremendous similarities between influenza and COVID-19. They are similar in presentation with the respiratory infections. They can be transmitted by contact, droplets, and fomites, and there's also the potential for airborne transmission, as we've seen the CDC and the World Health Organization change their opinion on transmission. They also require the same public health measures by using good hygiene and proper respiratory etiquette. However, the differences are to be noted. For example, influenza has a shorter incubation period, and the time that it can be shed to another person is about 3 days, where for COVID, the incubation period is usually somewhere between 5 and 6 days. For COVID, it's highly virulent, and it's far higher than for influenza. A COVID-positive patient can infect an average to 2 to 2.5 other people that they come in contact with. And of course, children, pregnant women, and the elderly are all at higher risk for influenza, and we want to assure that we are decreasing their morbidity and mortality because of strong vaccination clinics and programs. You may find that your pharmacist, for example, or your nurse practitioner can lead the way in demystifying the misconceptions about influenza vaccine and get to that 90% or greater of the 2020 goal that has been set for long-term care staff. And at this time, it is my complete pleasure to turn it over to Derek Darling for a few words on our vaccine program.
Wonderful. Thank you, Nancy, and hello, everyone. My name is Derek Darling. I'm the Vice President of Strategy, Marketing, and Internal Operations at Omnicare. Allow me first to offer a heartfelt thank you to each of the community leaders, administrators, clinicians, and other staff members on today's call. In truth, your efforts throughout the past 8 months have been nothing short of miraculous, and just know that you're very much appreciated. Now sort of pivoting here towards the vaccination space, and for all of the reasons that Nancy has introduced, now more than ever, prompt attention to preventing flu spread and getting vaccinations is absolutely critical. At Omnicare, we're very, very proud of the vaccination clinic infrastructure and service model that we've established in partnership with CVS Pharmacy, yielding many of the benefits that folks can see on their screen here today. And, Jim spoke to some of the details during his introductory remarks a moment ago, but in 2020, CVS Health expects to administer about 20 million flu shots, both through on-site clinics as well as in-store immunizations. Jim spoke to the experience and the credibility that CVS Health brings to COVID testing. And the reason I flag and raise both of these points is because, in short, CVS Health has the familiarity and the expertise to be your partner in fighting the spread of both flu and COVID-19. Now, specifically in regards to Omnicare's on-site vaccine program, it is a highly mature offering and consistently recognized as highly effective within long-term care communities. It's a program that actually started back in 2016, where we completed about 800 clinics, and just a short 4 years later, we've seen over 1,000% growth and we're well on our way to surpass the 8,000 clinic number in just this current twindemic season. And to the points that Jim was raising a moment ago, the program itself is operating with customer satisfaction levels in the 90s. So this is a highly effective program, and part of the reason why I wanted to spend a brief moment on it is because this fundamental on-site vaccination clinic model is going to be the chassis for the COVID-19 vaccination deployment that's going to be forthcoming here over the next series of weeks or months. For those facilities that have selected CVS Health as their on-site COVID vaccine partner, you'll be receiving additional information from us this week. And, without going into too much detail about that information, I would like to just say that it's absolutely critical that each of you, once receiving that initial outreach from CVS Health, please do provide us with updated contact information such that we can effectively communicate with you throughout the coming weeks in all of the various requirements that we'll be collaborating upon in order to have a successful COVID vaccine experience. So in closing, we are very, very proud to work with each of you to this point during the pandemic and also in the coming days and months ahead as we collaborate to fight the spread of COVID-19. And with that, I'll pass it back to Nancy.
Thanks, Derek. That is so helpful and reassuring to all of us to know the type of groundwork that's been done previously and how we can copy what we've done in the past to bring a best practice to each of the facilities who signed on with CVS and Omnicare for their COVID vaccinations in the near future. But right now, when you come to the reality of it, we're already stressed. We're stressed with flu season. We're stressed because facility staff may be ill. They are trying to juggle their children and their school day with their work day, and you have accommodated them as best you can. But still across the entire country, we are in need of nurses and other healthcare staff. So what do we do with this? How do we make things more efficient? How do we move quicker while not losing a clinical step or an operational step? How do we minimize risk management when there's so much pressure on us all? Well, as you all know, it starts with the best communication. And communication, as I've said before, is not just a thing that we do. It's not just a handoff between shifts. Communication is a real skill. And the leaders on this phone call are the ones that can help others with their skill set regarding communication. And right now, what we'd be looking at during the flu season with the pandemic is information about respiratory systems or symptoms in our residents. So when you take a look at what you will use, I'm going to bring you back to infection control and antimicrobial stewardship that is in for skilled nursing facilities as well as CDC supported for assisted living facilities. And one of the things that is common across any antibiotic stewardship program is the ability to use a tool, a founded tool based in evidence-based medicine that allows you to expedite a resident assessment and reduce nursing time by assuring that you have the right information at hand when you discuss with a physician a patient's or a resident's symptoms to assure that they get the care that they need. One of those tools, for example, is the SBAR. The SBAR stands for Situation, Background, Assessment, and Recommendation, and it was actually created by the United States Navy to communicate information on nuclear submarines. And as you know, that is the only industry that is more regulated, the nuclear power industry, than long-term care. The SBAR has turned out to be a powerful tool that's used to improve the effectiveness of a communication between individuals, and healthcare has embraced these types of tools, including things you may already be using like Medicare and Losben, to manage them and affect them to be strong communication pieces between healthcare providers. One of the things that you can do if you're not already using an SBAR worksheet is just look it up on the internet. You'll find a number of them for urinary tract infections, lower respiratory tract infections. You'll be able to find assessments to differentiate between viral pneumonia and bacterial pneumonia. And having these types of tools readily available in your infection control manual, taught and educated to your staff, placed into use to make the most valuable time of a telephone call to a prescriber to make sure that the message that you're sending is efficient and that the care that's delivered as a result of that communication is crisp, on time, and exactly what the resident needs. So as we further take a look at other areas of improved communication besides assessments when we see infectious symptoms in a resident, you want to take a look at where else we can evaluate today's communication patterns and then determine where we go from there. This is not something that your quality assurance team should ignore. I think these operational issues that confront you today need to be addressed soon, urgently, so that while we're preparing now for COVID vaccination, you'll be ready to receive those into your facilities that will be performing the vaccination. So remember, the Centers for Medicare, Medicaid, or CMS has published long ago what they called a program that was patients over paperwork. It was a true burden reduction and trying to find within long-term care, for example, where we can streamline regulations and have a different type of efficiency by eliminating unnecessary burdens. I think the prime example of patients over paperwork is the elimination of those 5 minimum data set assessments that had to be done in the first 100 days of a Medicare Part A stay. Well, if CMS recognizes it and they've already partaken of it, what can we do at an operational level within each of our facilities to start to minimize some of the unnecessary paperwork and just concentrate on things like resident assessment tools that helps us communicate effectively within our own facility and to outside providers? Keeping in mind that communication is the linchpin to patient-centered care, we have to build that skill upon relationships and trust. Solid tools, education, taking a look at other studies to understand within any business, what does good communication lead to? It's been proven to lead to better patient outcomes, safer work environments for our employees, and decreased adverse events associated with residents such as falls, and definitely improved transitions of care. I know that today, transitions of care documentation, especially from a hospital to a long-term care facility or an assisted living facility, is still not what it should be. Oftentimes, I, as a pharmacist, can take a look at discharge information, and I'm not finding what I think we need to care for the resident at handoff. So again, coming back to that piece of communication, these are the types of things that we can shore up today to assure that we'll be ready for the twindemic that is upon us. And you should also recognize that influenza is already here in many of our states, and as of today, there was a very high rate of influenza in Iowa, and it's been seen in North Dakota, Idaho, New Mexico, Oklahoma, Indiana, and Vermont. And there are some other states with very low rates, but it's coming. It's here. We're on the cusp. The time is now. In today's communication during a pandemic, who do we have to communicate with? How are we managing this? Well, first of all, you're not communicating just with staff. You're communicating with people who can staff your facility. Those either your HR person, your recruiter, your agency. We're diverting our time towards COVID testing every 7 days, 14 days, 28 days, and also communicating the results, recording the results, monitoring the results and when the next scheduled testing will be, learning how to use telecommunication or telemedicine, not just for physicians' visits, but we have seen in the pharmacy world, even nursing facilities use telemedicine or things like face chat to witness narcotic or controlled substance destruction. There's been process changes and more to come as we take a look at new policies and procedures that you'll probably begin to visit very shortly on COVID vaccinations. Your interaction with family and with residents has changed greatly. Sometimes you're standing at the door to speak to a resident who may be infected if you're not a hands-on health care provider, but you're also listening to families and working with them over video or calling them more often, but we certainly haven't been able to see them one-on-one. And lastly, there's the time to communicate. Now, you and I both know you cannot make time. If I open up a drawer, I can't find any time there. If I look in the med room, there's no time. What we need to do is figure out what we as operators in long-term care can do better, quicker, shorter, with the same quality to preserve time for direct patient care. When we take a look at what you can do to improve communication with outside organizations and vendors, make sure, first of all, that information of the day comes directly to you. I think that it's a complete waste of time for me to try and find out what's the update on a COVID vaccine, where is influenza prevalent today, what does the FDA say about nursing homes administering remdesivir or antibody therapies for COVID. That information comes to me because I sign up for selective distribution lists. I sign up with the FDA, I sign up with the CDC, and most importantly, I sign up with CMS to assure that as they send out letters about regulations, interpretation of regulations, or changes in regulations, that information comes to me, and I don't have to be surprised by someone else that I work with or one of our customers when something needs to change. Additionally, I encourage you to assure that you're on the distribution list from your county health department as well as your state health department to make sure that you're receiving the latest documents, the latest executive use authorizations, and other changes in policies and procedures set at a state or local level. But communication with your vendors and your support services takes an investment on your part. It can be a time investment. It may be a material investment. It may be a financial investment. What we really need to do is assure that we have some very crisp communication between our prescribers, certainly the lab, more importantly than ever, pharmacy, ambulance services, the vaccination clinics, and all of the other providers that support your facility. You are one of those employers where many other companies and many other businesses depend on your business to stay active. And as you are their customer, one of the things that you can do for them to abide by your side of the contract is to assure that they have the designated contacts on every shift and who they should be calling. For example, there may be a cell phone that's handed off from supervisor to supervisor to supervisor, where a manager at a pharmacy or the director of the lab can call that person directly with an issue that they may or may not have. And additionally to that, while we have a lot of electronic health records, I think we can all say that in long-term care, we're restricted or constricted by the amount of interface that we have with our electronic health records, and many of us are still using fax machines to communicate back and forth. So let's take a look at a best case solution let's see if we can think about the tools we have in a long-term care facility today and where we can take it. So let's look at this case study. It's about a drug contraindication. At last, you finally get a new patient that has a hip replacement admitted into your facility this evening, and you are happy to have that increase in census. The discharging hospitalist has ordered tramadol 50 milligrams every 6 hours for moderate to severe hip pain for 7 days. However, the resident is allergic to tramadol. The pharmacy has faxed the facility once that the drug allergy contraindication exists, and they've also followed up with 2 telephone calls. Once the nurse said he would call the pharmacy back as soon as he was done entering COVID-19 results in charts. And the next time when the pharmacy called, there was no answer, and the phone went to voicemail. Is there a way to overcome this true-to-life issue? Well, we have to think about it. We have to see what we have and where we can go. At the first call from the pharmacy, imagine this. From his secure cell phone that you purchased, that you gave him, the nurse called the admitting physician using his contact list already built up on that phone, received a new order for pain management, entered it into the resident's chart right from his phone, discontinued the previous tramadol order, and faxed it from his phone right over to the pharmacy. Yes, the phone has to be secure. Yes, contacts have to be set up on the phone, and they have to be copied from one phone to another and used on other shifts. But right now with these smartphones, you can actually copy contact lists from one phone to another, sometimes by just touching them. Yes, the phone has to be set up to access your electronic records, so it has to be web-based. Yes, you can download a printer app and send any documents you need printed to go out. Let's say with a resident that's leaving in the ambulance, you can have their complete MAR or their physician's order sheets ready to go by using your cell phone that has a wireless printer assigned to it, and they are ready to go with the resident. And you can use the phone to check the pharmacy portal to determine if an order is on its way. So I think we can all say that when you think about our cell phones today, they truly are little computers that just happen to be able to let you call someone. But we in long-term care are still not leveraging what we're seeing, including barcode reading capabilities that you can download onto the telephone that the facility is using. So when you take a look at what we really want to do here is this is a new day, new pressures, financial, clinical. What we need to do is take a look at new solutions. Remember that communication is a human resource and a capital investment. Senior care is probably not maximizing cell phones or tablets and their capabilities, and we need to discuss communication opportunities with your electronic health record vendor and your phone and Wi-Fi provider. It is one of the ways to decrease paperwork and increase time for patient care. 2 weeks ago, I had the pleasure of witnessing a hospital discharge. The nurse sat down using a cell phone and went through the medications with the patient before leaving the facility. She did another tap, and all of the directions for care at home and the next doctor's appointment were printed automatically on a wireless printer, and an aide brought them right to the room. It was at that time that the patient checked on the telephone that he had received that information and understood that information, and on that patient's telephone, the nurse put in a telephone number for him to call anytime he had a question. So we need to think about new ways and new technology, not by great expense, but by using ingenuity and asking more questions. In addition to that, I think since we spend so much time on pharmacy services in long-term care, especially with the great number of medications that are administered, I've seen up to 425 doses passed at the 9 a.m. or 8 a.m. med pass. And that is something that we do need to evaluate. So one of the ways to do that is prior authorizations. Now, about 1% of all third-party medications, and that's almost all of our customers, whether you're assisted living or skilled nursing facilities, require some type of prior authorization where the pharmacy has to transfer the order, have someone call the doctor then has to receive a fax from the third-party company or submit a form that goes in. And it is quite an administrative burden to the nursing staff, to prescribers, and to pharmacists. So what you really need to do is, in looking at the delay in patient access to some of these medically necessary medications, especially in the area of pain management or antibiotics, some states allow pharmacists to join with the physician into a collaborative practice agreement. These collaborative practice agreements would allow a pharmacist to obtain the prior authorization while the prescription was still in front of them. What they would be able to do is evaluate the rest of the medications that they have on board, take into consideration the cost of the medication, evaluate the formulary that's available on that third-party plan, or prove to the third party that with the ICD-10 code that you provided upon admission with that resident, we could get that medication covered without bothering the nurse and without bothering the physician. When you think about what happens in that type of communication, when pharmacy has to hold an order for payment, they call or fax the nursing home calls the physician then has to call the nursing facility back. The nursing facility gives us the new order, and if it's a controlled substance, now the pharmacy has to call the physician for a prescription. So there's 5 telephone calls that could be eliminated with a collaborative practice agreement if it's available in your state. And I would recommend that regardless of your provider, you ask if they're available. The other thing that you should know is that these are highly endorsed by the Centers for Control and Prevention, or the CDC, and what they say is it too is patient over paperwork, and it allows the facility staff to continue their care uninterrupted. And it is a viable question for you to bring to your pharmacy provider. In addition to that, automation and medication management is just on the cusp of actually being everything that it should be. It's had its growing pains in long-term care. Let's make no bones about that. However, multi-dose packaging is becoming even more commonly used in senior centers. It's being used in assisted living to promote independence, and it's being used in skilled nursing facilities to make the MedPass administration go quicker and more precisely. There may be special blister card packaging. I'll bet some of you never knew that if it takes 2 tablets or capsules for a single dose, that a pharmacy can put both of them in a single blister, keep it easier for you and the nursing staff to administer that medication. And also there's automated dispensing machines, not just for first dose access and real-time access to medications, but there are even automated dispensing machines that will be able to go ahead and dispense an entire MedPass at real time, so that a nurse went over to the machine and asked for all of the medications due for the 8 a.m. MedPass for rooms 101A to 105B. They would just come out on a roll ready for her to, or him, to dispense and administer to the resident. Automated refill systems are also another place where you can go. Barcoding to refill medications eliminates requesting refills all at one time. The pharmacy should be sending you a list of what is ready to be refilled, and then you can go ahead and you can review it, sign it, and send it back to the pharmacy so that you don't have to be bothered with scanning every single label every time you need to order a medication, or pulling off a little sticker and putting it on a refill sheet to fax to the pharmacy. The pharmacy can even predict which medications may not have any refills left or maybe a year old. and they can work with you in advance to get new orders or new prescriptions for a resident. They can even tell you medications that have a stop order, like antibiotics, to remind you to determine whether they should be refilled at an end and discontinued from the resident's chart. But again, we need to take advantage of the automation that's available to us and embrace it. If you had cell phone technology, that could be your barcode reader just as well as a manual one that's left on the top of your card. But here I really want to address deprescribing. There was a study done, and it took a look at long-term care medications and how long it took to give a single medication in a long-term care facility. It took 45 seconds for a medication that was already on board to pass one single drug. It took 63 seconds for a new medication for a new resident. So when you take that total cost, what you're looking at is the cost of adding an oral medication once a day for a patient will cost you about $8 a month in labor hours if it's even administered at the same time as the other doses. And it will cost you $11 a month for any new single order if it is brand new or for a new patient. So what we really need to do is take a look at how can we lower the number of doses, especially on that morning med pass, or the off-hour medications that are given late at night, too early in the morning, disturbing residents at 5 a.m. because it has to be taken on an empty stomach. What your pharmacist can do is take a look at other dosage forms, things like medications that last 24 hours and are only given once a day. If a medication has to be crushed, let's find the liquid variation of that medication to make sure that it's easier, it's quicker for the nurse to measure and administer. Look at patches. Let's take a look at injections even. Some of the insulins that we're using are rapid acting, and some residents can be changed to a longer acting insulin that may be used fewer times during the day. So the solution is deprescribing unnecessary medications to decrease the time your nurses spend in giving medications. Again, moving from paperwork to patients. So where do you start? Well, working with your pharmacist, what you want to do is take a look at any medication that's really not needed or doesn't improve the well-being of the resident. And that includes anything that's unfounded, something that has no science behind it. So you may be thinking, for example, high doses of magnesium doesn't necessarily heal all wounds. Not everybody who eats 100% of their meal needs a vitamin. Herbal remedies have to be brought in sometimes by the family, and yet you're there to deal with a multi-dose bottle of medications. And we also have Beer's List medications of potentially inappropriate medications in seniors. We can change these dosage forms to once a day. We can move them to different times of day. We can eliminate unused PRN medications. We can use metered dose inhalers instead of nebulized medications, especially during outbreaks and pandemics. Discontinue medications where the labs show it's no longer needed. Why do we continue to give the iron to residents who are no longer anemic? Why do we continue to use a debriding agent for a wound that no longer needs to be debrided? Why are we using antibiotic eye drops after cataract surgery when it's only indicated for a couple of weeks? So what you can do here is take a look at what is not necessary and focus your consultant pharmacist on the task at hand. Yes, we know regulatorily they have to take a look at irregularities in the medication regimen and point that out to the physician for action, but also eliminate the unnecessary medications that our residents are using, all of the myriad of stool softeners and vitamins that are not necessary, and get them out of the way. And even if you have some of those that you'd like to keep for PRNs because you don't want to bother a physician at midnight for Maalox, if that resident's never taken Maalox, that's one less order you really have to deal with, and you can then focus what you need to be focused on, and that's the resident. So while I know that some of this comes from very high levels, and some of it for you might even be a little wishful thinking, I think what we need to do is use that communication skill that we have, embrace it, nourish it, transpose it across all of the other areas of your facility, and begin to take on the role of less paperwork, more focus on our residents, not only during a pandemic, but to use this as a best practice thereafter in each of your facilities. And with that, I'd like to thank you for your attention as always. It's a privilege to speak to you, especially through a Ignite seminar where you are able to get your CE. And I'm thrilled to be invited again to have done this. I hope you received some good items for you to discuss tomorrow when you start thinking about the operations in your building and how we can eliminate unnecessary work and really focus on the residents who are going to need us. Remember, some of these vaccinations that are coming up require you to monitor the residents for a good amount of time after they're given, and you need to be able to not find the time. We need to make the time, and that means unnecessary things that we do in a nursing facility need to fall away. They're not tradition, they're innovation. Thank you, and I think we do have some time for questions.
Yes, we do. Thank you very much for all that great information, Jim, Nancy, and Derek. Now we'd like to take questions from the audience. Anyone with a question can type it in now using the questions and answers tab to the left. We'll get to as many questions as we can in the remaining minutes. Our first question comes from Vivian, who's wondering, if you have independent residents, can CVS go to the facilities to give flu shots?
Yep. And Lois, this is Derek. I can take that. The answer is definitely yes. So for LTC independent living facilities, we can work with you directly to schedule and conduct an on-site flu clinic experience, much like we could host one inside of the skilled nursing or other senior living types of settings. But assuredly, yes, for independent living. And if you're interested to learn more, you can follow up with me directly or visit the Omnicare website.
Great.
Derek, it's Nancy. I'd like to piggyback on that. And while we're very efficient at influenza vaccinations, our seniors still need perhaps their first or their second pneumonia vaccination, as well as shingles. And as you had seen from Derek's list, there's an array of vaccination programs that we have, and our pharmacists are capable of delivering to your residents to keep them well and healthy.
Thank you. The next question we have is, do you think senior living residents will be willing to be vaccinated for COVID with any of the new vaccines that are awaiting FDA approval? The same thing, I guess, could be asked for skilled nursing residents.
It's Nancy. I'll take that one. I do think that they will want to have the vaccine, and I'll tell you why and how you can convince them, and I'll put Derek's marketing hat on for a moment. The seniors today in long-term care, regardless of setting, all lived through polio. When they were little, they all went to the public school or to the county office, and they all received their oral polio vaccine. It was cherry, it was liquid, and it was put on a sugar cube. During their lifetime, the seniors in nursing homes and assisted living facilities today saw polio eradicated from the United States. And it is that story that I would use to remind them that vaccines are not harmful. There's not a single vaccine, whether it's flu or it's going to be COVID, that has any live vaccine whatsoever in it. They know the miracles of vaccine because they have seen these diseases wiped out. No, they have old smallpox scars on their arms. They've been through here. sometimes they forget that, and that's how I would leverage their own history to get them to sign on to the COVID vaccination.
Thank you. Here's a question from Catherine. Our staff members are not interested in getting a flu shot because they're wearing masks. Do you have any thoughts on that?
Well, they may be wearing masks in the facility, but they're not wearing a mask everywhere else. And while they should, certainly we know that influenza could be brought home from their spouse's work, another family member. My goodness, we have Thanksgiving coming up. It's just like COVID. We really don't know who may have influenza and is still asymptomatic. So while a mask is wonderful, it's not the be-all, end-all when it comes to respiratory diseases. I think that we can all say, hey, we're all wearing masks, but we're still getting COVID, right? So it doesn't make much sense to put off having a flu vaccine. I did answer a couple questions from customers. One was she had heard that vaccinations were made and manufactured by the use of eggs or fetal material. And, you know, we tried to tell her that these aren't human fetuses. These are chicken eggs that are being used, not human eggs that are being used to manufacture vaccines. Another one was a vegan, and she didn't want any protein that was derived from a chicken in her vaccine. And yet we have one brand of flu vaccine that has no protein whatsoever and is not produced using chicken eggs at all. So there's a lot of questions that people have out there, and I'll bet a good pharmacist has an answer for all of that.
And here's a follow-up related to a previous question from Maggie. What do you do if a senior living resident or staff member refuses to take a vaccine and you mandate it?
Well, thank you for the question. It's an interesting one. You know, there's always residents' rights. We might mandate it, but up until the moment that you're ready to inject that needle, they have a right to say no. The best that we can do is truly aim for 90% or above for all of the residents and staff to be vaccinated so that we have a herd immunity. And of course, you're going to have to monitor them. And it's never too late in the season to get a flu vaccine. And I doubt it'll ever be too late to get a COVID vaccine. We might see one annually for all we know. It is now time to convince them. And sometimes it takes their doctor. More routinely, we see that we have clergy that is very good at convincing people to get their vaccination, and that it is something that they can do not only for themselves, but do it unselfishly for others. So use what's available in your community outreach, and your pastors and priests and other religious can come into your facility and help with that in terms of convincing them to have their vaccinations.
Thank you very much for that answer, and thanks for the answers that you provided too, Derek. I think that's all the time we're going to have for questions today, but if you had a question and it wasn't answered, you're going to be followed up with, so you'll receive an answer. We hope you found today's webinar helpful. This session will be available shortly to listen to again online at the address you see on your screen, which is mcknightseniorliving.com/111720webinar. We'd like to give special thanks to our speakers, Jim Love, Nancy Losben, and Derek Darling, for being with us today to share their insights. And thanks to our sponsor, Omnicare, a CVS health company. You can visit omnicare.com to learn more about the company. And thanks to everyone listening today for tuning in and asking those questions. For McKnight Senior Living, this is Lois Bowers.
Thank you.
Thank you.